Hello, this is Daniel Wolfson from the ABIM Foundation and the Choosing Wisely campaign, and I'm joined by Catherine Sarkisian from UCLA. She is at the Department of Medicine at the David Caffin School of Medicine, and she is heading up one of the the grants from the Robert Wood Johnson Foundation, and she's working with the LA County Health Services Department, who is the delivery site, and UCLA is the evaluator working to evaluate the impact of their interventions. So, Catherine, welcome.
Thank you.
Would like to know, first of all, how you guys, thought about getting involved in Choosing Wisely, and the origins of your relationship with the LA County Department of Health Services, and how this all came to be.
Oh, thank you. Well, I'm happy to. So I'm a geriatrician, so I take care of a lot of older adults, and I have aging parents myself. And my research has really, my team that I lead at UCLA is really focused on helping older adults in the community take care of their own health through health promotion, physical activity, eating well, taking their blood pressure medicine. What the term that we think of it is demedicalization of their health, demedicalization of aging. So that's really what I've done for the last 20 years with a very interdisciplinary team, very connected to community partners around LA County, this very diverse city, mostly with underrepresented minorities, but not exclusively. And then about 3 years ago, well, when I first learned about the Choosing Wisely campaign, it really resonated with my personal passion as a clinician and as a daughter of how terrible it is that so many patients are getting way too much care. And I found myself in clinic telling patients, hey, instead of getting that test, why don't you call your best friend and have a good conversation? Take your best friend out to lunch. You don't need to go to all these specialties. It's just so depressing to me to see people just, their whole life is medicine and instead of health. Health and medicine are such different constructs. So I just loved the Choosing Wisely campaign, and my team and I wrote a PCORI application about 1.5 years ago, which we thought we were just perfect because we're really connected to the community, and it's a really interesting campaign with underrepresented minorities. In fact, when we first pitched the Choosing Wisely campaign to some of our wonderful, wonderful community partners, their first reaction was, no way. Like, we have people who we've been spending the last 25 years telling them to get enough care, and now you want us to go back and say you need to get even less? They said, absolutely not, we will not do it. So we really stepped back and said, well, what is the conversation that we need to be having, and how can we talk about this? And I had the opportunity to connect with Tara Montgomery at Consumer Reports, who said that this was something she was really, really interested in. And anyway, we didn't get the PCORI grant, but we stayed very, very interested, and then had the opportunity to compete for this application. And I had known Anish Mahajan, who is the director of the data team at LA County Health Services, because he used to be on the faculty at UCLA. There's a lot of cross interaction between UCLA and Department of Health Services. And then my co-PI, Jennifer Sales, she actually used to be on the faculty at UCLA as well. And so I reached out to Anish, and he connected me to Jennifer, and it was just a natural fit because it aligns so well with what the DHS is already doing. I mean, it's the second largest safety net provider in the country. They provide, millions of outpatient visits, and they are really being very proactive in quality improvement, and in particular, the part of quality that has to do with reducing low-value care. So they had already implemented a clinical decision support system to reduce imaging for low back pain and other conditions. So they were really excited about the opportunity to partner with our team to increase the evaluation, hopefully increase the impact of the work.
So tell us what you're going to be working on as far as the tests and procedures, and also how you expect to increase awareness of the issue among an underserved population.
Yeah, great question. So the three conditions, as you know, that we are focusing on are reducing imaging for low back pain, decreasing antibiotics for viral upper respiratory infections, and decreasing needless preoperative labs for routine cataract surgery. And so we have a 2-level intervention. The first year, we're going to really focus on a provider level intervention, including clinical decision support, education, and some things that we're really excited about. We've had the opportunity to partner with a couple of behavioral economists, and we're actually trying to bring in some really exciting, innovative, low budget interventions, such as commitment pledges on the walls of clinicians saying that they are committed to not prescribing antibiotics for viral infections, and things like this. Competitions among the house staff to see who can provide the least low value care. And so really excited about the provider level intervention, and that'll be in the first year. But then exactly what you said, so we thought, well, we need to have a survey to inform our patient level intervention, because we don't even know. We thought, well, we should ask patients, when you go see the doctor with low back pain, do you want an MRI? Other people have done really good surveys on this in other populations, but we thought, well, we really need to step back. Patients might not even know what an MRI is. I mean, as you're very familiar with the literature, a lot of times physicians assume their patients are coming to them demanding an antibiotic, demanding an MRI, when in fact, they actually just want reassurance. And they want the doctor to take the time to work on shared decision making and explain to them. But so we are actually spending. We spent the last couple months working on a survey that we're going to administer in the waiting rooms and in the emergency room and urgent care clinics, all in Spanish, Spanish and English. But it'll be, the population is about 80% Latino here. And so we are going to really we're asking people who have back pain and upper respiratory infections, why are you here? What do you expect from your doctor today? What do you want from your doctor today? And then that will inform a patient level intervention in the second year.
So talk about the pre-commitment intervention. There's been some work done at the University of Michigan on this, and testing it, a behavioral economist working on that intervention. It seems quite promising. Could you describe that a little bit?
Yeah, well, we're in the early stages of figuring out how it's going to work in our setting, but there's actually a professor of economics at USC named Jason Doctor, who published a paper and he had some NIH funding to look into this, and he got at USC, which is a partner institute, is also, even though I know UCLA and USC are rivals, we're very collaborative, and USC actually works with Department of Health Services as well. So he did an intervention, not in the safety net part of USC, but in the private hospital, where the clinicians made a pledge, and they all got together and they said, we're not going to do antibiotics for upper respiratory infections, and they put big banners in their offices, and they reduced antibiotics for upper respiratory infections, I think over 25%, and it was so low cost, and the doctors were on board, and when the patients would ask for antibiotics, they would literally point to their banner and say, well, I'm committed, and so it was really successful. So we're excited about it.
It aligns well with professionalism, I think, giving the autonomy of the patient and the physician to make the right choices and make them up front when they're not under pressure. I think it has lots of promise.
That's a good point. I like the idea of linking it to professionalism. Another idea that we're working on is charity for performance. So rather than paying providers who do, provide higher quality and less low value care, but actually saying, hey, giving them a letter at the end of 3 months and saying, based on you're providing high quality care and less low value care, you just saved, $20,000 in the last 6 months. And on behalf of that, we are donating, X thousands of dollars to provide increased community services for these low income patients or something.
That's
like
great.
I love that. I have to thank this funding mechanism so much. We had the opportunity to meet with Scott Halpern yesterday, thanks to your connections. And he is just such a smart guy, helpful guy. And he had a great suggestion. He was suggesting maybe a lottery, because we don't have a ton of discretionary funds, so we can just, give all this money to the residents. But with putting the residents into teams and saying, okay, whatever team gets the lowest, has the most low value care, or I'm sorry, the least low value care, then you enter a lottery to win an iPad or, a trip to Las Vegas or something. But, being in a lottery as opposed to just giving out the prize. So
well, I think competitions, particularly non-financial competitions, when it's just reputation and your own self-worth, really have promise. And we've seen a lot of competitions in residency programs around the country, really engaging a whole swath of young people and young faculty too, around how to advance choosing wisely. So you got two great interventions, and I think you're going about listening to the patient and patient's needs quite nicely. So tell me, Catherine, what are some barriers that are keeping you up at night?
Well, I mean, I think the biggest thing for me personally is I don't work at LA County Department of Health Services. I work at UCLA. So I've had a very steep learning curve about how the system works and how their computer system works. And we've been spending a lot of time driving out to meet with the different experts in the clinical decision support and really spending the time walking through the ordering system and going over the data analytics and finding out, a lot of the problem, I'm sure you know, the problem with clinical decision support is that people can always find a workaround, right? So that huge number of people who type in, one of my favorite lines was the person we were working with in the data analysis section. She said the favorite thing is ASDF. People write reason for that they can't do this, or they have to order it, ASDF. Because if you think about it, it's just it's the keyboard, right? ASDF. They type in ASDF. So it's like so frustrating. So steep learning curve, learning how things are, and then we had this huge challenge that the brand new electronic health record at DHS, which is great on the one hand because it's going to be a better health record, but it also pushes back the start of our project because we felt very strongly to get meaningful results, we cannot use data from the old health record and compare it to data on the new health record. So we need to push back a little bit on the timeline. I guess that's the big challenge.
Are you embedding the clinical pathways into the electronic medical record?
For the back pain, yes, not for the cataract surgery labs or the antibiotics.
Well, it'd be a nice comparison to see the relative impact of.
That's a good point.
Of the EMR.
Well, and then the other really exciting thing is DHS actually has 5 different ambulatory care clusters. Some are associated with hospitals, some aren't. And the rollout of the electronic health record and the clinical decision support is different at each site. So and one of them doesn't roll out until much later. So we can use that as a control site. We're hoping to do a kind of difference in differences analysis, comparing the site that didn't get the clinical decision support.
What clinicians are you working with to decrease cataracts?
The head of the Rudy Amaya, I think he's an anesthesiologist. Who is our head ophthalmologist? I have to look up the name of our head ophthalmologist. We're having our big kickoff meeting for the ophthalmology group December 1st.
Was it the decreased tests before cataracts or the decreased cataracts?
Decreased tests before cataracts.
Okay.
But we need to have the anesthesiologists, who do the pre-op clinic, we have the ophthalmologists, and some of them, we've been getting a teeny bit of pushback. They want to have the test. So we're really having to do a lot of teaching and explaining, but it's good. And DHS, this is, it's not like UCLA is just jumping in and doing this. DHS has been working on this before this grant ever came around. And they have a performance improvement team with this wonderful woman from their quality improvement team who has been really taking charge. And now that we have a project director funded through this grant, they're kind of joining forces to really increase the impact of the work.
My personal experience has been that it's been the anesthesiologist that's a hurdle to reduce the pretest for EKG. I have my story of my 4 EKGs for 2 detached retinas and 2 cataracts.
Oh, that's terrible. That's terrible. Yeah, I think that sounds about right. We'll see when we go to our big meeting on December 1st. I think that sounds right. The anesthesiologists want all their information. Well,
anything else you want to provide the listeners with about your program? What do you see? What do you see at the end of this grant? What's success going to look like? What's your measures of success for this program?
Great question. So first of all, actual reduction in low value care for each of our 3 three conditions. Huge, hopefully over 25%. That's our main metric. But then also a how-to manual that could be disseminated to other safety net providers around the country. So there are certain things that are particular to Latino culture that I think would be of interest to other large urban safety net systems. I hope that will be. And then I hope these new, like I said, Scott Halpern didn't think anybody was really working on this charity for performance model. So I hope that we can publish a couple cutting edge papers in high impact journals. It's one thing that I forgot to mention. It was on my progress report. We had great timing. Dr. John Maffei is an assistant professor who started in August at UCLA, who came from Beth Israel, Harvard, and he's actually very interested. I met him at he came to dinner at our home because my husband is a senior faculty in John's division, general medicine, and we were just being the nice host to the new faculty, and I said, "So what's your research on?" He said, "Oh, reducing low value care." And I said, "Oh my God." So it's great, and he's really smart and creative, and he's been a lot of fun to have on the team as well. So
some good scholarship coming out on the issue of overuse now, because I think it's so related to good decision making. And they go hand in hand. Yeah, it's really exciting. And then, well, I mentioned this, I alluded to this, I think, before we were being taped. We're really excited about hopefully getting putting together a coalition of scientists and interdisciplinary teams working to reduce low value care at UCLA. So we've been meeting with key stakeholders across UCLA, leadership. I told you we're meeting with Dr. Braddock next week, and there's some really interesting work being done at UCLA, but it's not all synchronized. There's people in urology and people in, in cardiology. And so we're trying to bring everyone together and solicit funding for a center to reduce low value care at UCLA. Right. Well, I want to thank you, Catherine, for spending this time with us. This has been a really wonderful exchange of ideas and information. And for people who want to read more about innovations and implementation of Choosing Wisely and what the grantees are doing, please subscribe to the reports from the field by going to www.choosingwisely and clicking on resources. Again, thank you very much, Catherine, and look forward to seeing the results of your fine work, particularly working with a safety net hospital and system.
Thank you, Daniel.